Thank you very much, colleagues, for your patience as we wait to hear from the others and as we work on the technical aspect. Okay, thank you, Helen, for confirming. So it's confirmed that you can write in the chat. So please do let us know where you are joining us from, your name, where you're joining us from, and your organization. Is it possible to write in the chat box now? Edna, please confirm. And Maria, please also confirm if you're now a panelist. Oh, wonderful, wonderful. Thanks, Edna. Okay, so I'm looking forward to hearing from everybody else where you are joining us from. Thank you, Lusungu, for joining from Malawi. Thank you, Jeremiah. Thank you, Sakinat from Nigeria. Thank you, Raza. Thank you, Hari. Wonderful. Oh, amazing. Thank you, Rahim. Thank you, Richard, Helen, Nicole, Alan. Say hi. Wonderful. Our numbers are going great. We will start in about 2 minutes. Thank you for your patience. Thank you, Emily. Thank you, Mohammed. Thank you, Sylvia. It's nice to see you. Thank you, Patience. I see Zambians are winning. Kenyans, mobilize yourselves. Yeah, I see Kenyans now coming in, but I see Zambians. I see someone from Deepak from Nepal. I see Carol from South Africa, Alfred from Tanzania. Oh, Tanzanians are also coming up. We're doing great. Nick Njoka from Kenya, Dora from Uganda. Thank you very much, colleagues. I see the names coming in. Thank you. I see colleagues from Lesotho, from Namibia, South Africa, Malawi, and it is safe to say we are all very well represented now in this call. So I'm now going to turn on my video so you can see me. Just confirming if all the speakers are in. I see the introduction still coming in.
All of them are in.
All of them are in. Wonderful. Okay, thank you, colleagues. Good afternoon, good evening, good morning, depending on where you're joining us from. My name is Joyce Amondi Ouma. I am the Regional Youth Officer at UNAIDS, Regional Support Team for East and Southern Africa. And I have the pleasure of co-facilitating this session with Lisa Marianne, who you will meet shortly. Or Lisa, do you want to say hi now so they can acquaint? I know they know you. Just
Yes,
checking if your systems are working.
Yes, I can say a quick hello, although I'm still trying to manage a bit of tech, but I'll come in during my session. Thank you, Joyce.
Great. Thank you very much, Lisa. Always a pleasure. Okay, so it's nice to meet everyone, and once again, really thank you to the Eannaso team and the Anglophone Africa Regional Learning Hub, the Global Fund, AIDS Funds, UNAIDS, LVCT Health, Y Plus Global, Gilead, Empower Fund, Health Alliance, Preparing, AFA, and IPM South Africa. We have a wide range of partners on this call, as well as excellent participants. So I'm really looking forward to the next few minutes being very resourceful. So if you have not introduced yourself, please feel free to continue introducing yourself in the chat. We are monitoring the chat just to see where everyone is from. Thank you for the colleagues that are beyond East and Southern Africa. Thank you for the colleagues beyond Africa. It means that this is a conversation that transcends borders. So as we all know, the HIV prevention landscape is evolving incredibly fast with new biomedical technologies that have potential to completely reshape how we design, deliver, and access prevention services across different populations and different settings. And during this season as well, countries are advancing their Global Fund Grant Cycle 8 funding requests. And this is the best time for our prevention conversations to move past whether to fund prevention and to squarely agree on what are the choices to prioritize for whom and how they should be delivered. The specific objectives for this session, as you may have already know, is that just recently we had several countries in East and Southern Africa and across the world launch the new prevention technology, lenacapavir. And lenacapavir is not the only option that exists. It's just an addition to the many options that already exist. And throughout this session, you'll hear more about Kabele and the pivirine ring and all the other prevention technologies that we have. So we at UNAIDS are constantly advising to advance the aspect of combination prevention. And, because there's been many HIV prevention tools in the pipeline. The goal of today's webinar is to strengthen awareness and dialogue and community engagement on emerging long-acting HIV prevention technologies and their implications for HIV prevention prioritization, delivery models, and funding decisions within the Global Fund Grant Cycle 8. We have a few objectives as well to complement this goal. The first objective being to increase community awareness and understanding of emerging and long-acting HIV prevention options, including some which you may know of, the dapivirine vaginal ring, the long-acting injectable PrEP, two of them, Kabele and lenacapavir, and their potential role within national HIV responses. The second objective is to explore how developers, donors, and technical partners are approaching access, affordability, community engagement, demand creation, and implementation readiness for new HIV prevention technologies. The third objective is to examine how countries and communities are currently integrating HIV prevention priorities into the ongoing GC8 funding request and development processes. How are they prioritizing, and what are the implementation realities at country level? This conversation will also facilitate a dialogue amongst adolescent girls and young women, adolescents and young people, key population constituencies on the community priorities, prevention choice, and opportunities for equitable access to long-acting prevention options. And finally, this webinar aims to identify practical recommendations for strengthening community engagement and to ensure HIV prevention investments within GC8 and to ensure that they're responsive, equitable, and aligned with community needs. So that's a lot, that's a mouthful, but it's a good thing that we have 2 hours and we have technical partners, we have civil society on board, we have the developers, we have the funders on board, all who have generously contributed to the convening of this session. And so I would like to check if I have a good talent in keeping time, so we are not going to lag behind today, hopefully because of time. So I would like to quickly check if our speakers are on board. And for those who are just joining us, thank you very much for joining. Please keep introducing yourself in the chat with your name, your organization, and the country that you are joining us from. Remember, one of the objectives of this session is to promote collaboration, cross-learning amongst different communities as well. So keep your introductions coming, keep your introductions coming, keep your introductions coming. So I'd just like to quickly check if we have the following speakers on board for our kickoff session on the Prevention Innovation Spotlight from product development to community access. Just checking if Dianta Pillay is on the call, Emily Gibson, Noma Kosi, and Auntie Yvette. If all of us are on the call, please give me a thumbs up. Oh, wow, it's so nice to see you. It's really nice to see you all looking very beautiful, lovely. Yay, I love the energy. Thank you. So yes, I think we will start with Dianta. I hope I'm pronouncing the name correctly. Dianta, please, as you unmute, please also introduce yourself, the organization that you're from, where you're joining us from, because you look very bright. Is it morning where you are? And in the same context, please also share with us what is the current thinking around rollout readiness, including accessibility, affordability, procurement pathways, and implementation considerations that countries should have in mind as we continue to progress in GC8 on PrEP, Ring, and lenacapavir. Thank you, and over to you. I saved you a few minutes, so you can, yeah, thank you.
Fantastic. Thank you so much, Joyce, for that very warm welcome. So, as Joyce mentioned, I'm Diantha Pillay. I am joining from South Africa, Johannesburg, from IPM South Africa, an affiliate of the Population Council. So, we are the product developers for the Deprivaline Vaginal Ring. And to your question, Joyce, it is the afternoon at 2 p.m. I just have very good lighting in my office. Um, so I am very excited to be on this webinar and to speak a little around what us as an organization are doing in terms of accessibility, affordability, procurement pathways, as well as implementation considerations, looking specifically at the Deprivaline vaginal ring, or what we call the PrEP ring. So I would like to premise by stating why choice still matters here in 2026. We understand that HIV prevention choice is not a one size fits all approach. We understand that if we do have a one size fits all approach, this will leave significant gaps in motivation, in access, as well as effective use. So, offering multiple options increases uptake, it increases correct use, it increases satisfaction. So, ideally, like in a contraceptive portfolio, we would like to see as an organization a basket of prevention that women can choose from based on their lifestyles. And we know this choice is not static, it evolves over time. So, just spotlighting on the PrEP ring or the Deprivaline ring itself, just to highlight, currently as it stands in terms of accessibility, 10 countries in Africa have approvals from their local medicines regulators, and we have 2 countries that have an import permit. In addition, we've also developed a pipeline product, or what we call a line extension product, from the monthly Deprivaline ring, and that is the 3 monthly Deprivaline ring. So, as product developers, we want to remain in touch with the communities that we serve, and we know that more convenient products are always needed, hence the birth of the 3 month ring. At the moment, the 3 month ring is currently under the review of the EMA. So we're hoping for a positive opinion, hopefully in quarter four of 2026 or early quarter 1 of 2027. But please don't hold me to that as we are at the mercy of their timelines. So I'd like to spotlight a bit around affordability. So we are all very, very well aware of what has happened in our space recently in terms of global funding cuts. We understand how this has reduced our ability to provide choice significantly. So, as an organization in December 2025, we opted to subsidize the price of the ring. So, we dropped the price of the ring from $12 to $13 per ring to about $5.90. And this was through a subsidy that we provided through the Population Council. So, this is a 54% reduction in cost. So the annual cost of a ring right now of 12 rings would be around $70. So this brings it very close to what you would pay for oral PrEP. In addition to that, we've also looked at the 3 month ring. So the 3 month ring now under regulatory review for a year cycle, you would only use 4 rings in a year. And that then drops the original cost of the ring to about 60% of its original cost, making an annual cost of $52. So again, we ensure that affordability is a key aspect that we look at as product developers. We are trying to aim to bring the price as close as possible to oral PrEP. And we understand when ministries and implementers make decisions around including a product, they think of affordability also in the lens of efficacy. So, is an intervention efficacious enough in relation to the cost? So, we know that initially, when clinical trials were done for the ring, it showed a modest efficacy. But what we're seeing from sub analysis data from these clinical trials, as well as emerging implementation data, it's showing a much better picture in terms of improved efficacy from what we've seen in clinical trials. So, that brings us to quite a positive signal, both in terms of affordability and us reducing the annual cost of the ring and its effectiveness out in the population. And then I'd love to speak a bit around the procurement pathways. So, as it stands, currently the Population Council is managing the procurement of the ring. So, orders are being placed directly through the Population Council through our DVR sales team. So any order will come through us and we process it. Also, in addition to looking at the significant funding losses we have globally, which we know includes funding losses for supply of commodities as well as programs, we have responded by creating a donation mechanism. So countries who are interested in providing the ring are welcome to harness our donation mechanism, and we provide small quantities of rings to various pilot studies, to the ministries of health who would like to test out the ring in small pilots. So in that way, we are, one, able to provide the ring through our own procurement pathway, which we manage. Then looking at implementation considerations, product adoption is very closely linked to effective demand creation strategies. So what we've seen is that greater investments in product awareness and choice is essential. So we have a very robust social media campaign and social media strategy that spotlights multiple HIV prevention products. And in order for a product to be taken up in the community, there really needs to be significant awareness. We understand, given the funding challenges, that this demand creation has suffered in recent times. What we've also seen from implementation studies is that there is a subset of women who choose the ring and they remain consistent in terms of use. We are currently analyzing implementation data from various studies to try and identify what are the characteristics of these women who are remaining adherent to the product and are able to use the product over a longer period of time. So we understand that the ring is a niche product. It will not suit every woman, but it does suit a subset of women. We have also learned valuable lessons from implementation studies and also the rollout in various countries on the benefits of differentiated service delivery. For example, I'd love to spotlight Eswatini. Eswatini has made great strides in terms of including choice for HIV prevention. They've also piloted community provision for the ring, which is shown to be a very valuable strategy. So in terms of looking at the simplicity of the ring itself, it lends itself to community provision. It doesn't require any special storage. It is a self-administered product as well and has quite a long shelf life. So looking at Eswatini's community provision, we can see benefits of a non-traditional facility-based approach through mobile facilities, but also harnessing a cadre of staff that often gets overlooked, the community healthcare workers. So there's definitely a space where we can look at different implementation pathways in order to provide improved choice. And just to spotlight countries that have moved forward in terms of including the ring as part of the HIV prevention method mix, it is both Eswatini and Zambia who have launched the ring nationally, and they are proceeding with differentiated service delivery.
Sorry, Diantha. Sorry for interrupting you. Are you sharing slides? Or is speaking
I'm
from?
not. I'm speaking.
Okay. Oh, excellent. Yes, colleagues. So don't worry, we are not missing out on anything. It's just listening.
Great. So I think all that being said, there is still very much a role for including the Deprivarin ring as part of a prevention package. We know that there are women who are interested in the product, who benefit from the product. We understand that it is a niche product, and we are committed to providing the ring to whichever country is interested in procuring the ring. So through our mechanisms of both donations and procurement, we still remain committed. In terms of looking at concrete actions in this window where we have GC8 funding or writing for GC8 funding, we encourage partners to consider the ring as an option because it does fill a gap of women who may not choose to use an injectable or oral pills. So Joyce, I'm going to pause there and hand back to you.
Great. Thank you very much, Diantha. That was really Excellent. And I loved listening, and I was trying to also catch up with notes, and I see colleagues also asking if there are slides that they can see. But I think a lot of this work is also largely online. So we can find it on your website as well. So please, if there's any sources of information that we can leverage on, please do share them in the chat. I'll get back to you. There's questions for you already. But in the meantime, colleagues, keep your questions coming in the Q&A section as we move to our next speaker, who I'm informed has to step out soon. So the next speaker is Emily Gibbons from Gilead. Emily, I hope you're still with us. Oh, wonderful. Yes, I can see you.
Yes.
Wonderful. So I will ask you the same question that I asked Diantha on what is the current thinking around the rollout readiness, including accessibility, affordability, the procurement pathways, and implementation considerations for countries as they prepare for GC8, for preparing, and of course, in this case, for lenacapavir. Over to you.
Sure, and thank you so much for having me. It's a pleasure to be here. I am calling in from Nairobi, Kenya today, though I'm normally based in Washington, D.C., and actually just finished a meeting with many advocates, civil society, and other global health partners on how to ensure accessibility for new prevention options. So this is very timely. First, I'd like to say that I agree with both your opening comments and the previous speakers. We're really excited about lenacapavir. It's our twice yearly HIV prevention product. It was approved by the US FDA last year, but we firmly believe that this should be one of many PrEP options, not the best PrEP option is the one that people actually want to utilize. So recognizing that there are a number of really wonderful products on the market already, and really just want to encourage people in the countries and the funders to enable choice for all people. So what I thought I'd do to talk a little bit is about how we got here, because today there is lenacapavir in 10 countries in sub-Saharan Africa. And thanks to our partnership with the Global Fund and PEPFAR, we anticipate that lenacapavir will be in 24 countries in low and middle income countries settings by the end of the year. But we wouldn't be in this position without so much advanced planning, which I think is very key to Gilead Sciences, but also to all product developers going forward. So as I just mentioned, we received stringent regulatory approval last year, but our engagement with community and global health stakeholders really preceded that by many years in advance. So initially, when we were designing our clinical trials in 2019, we worked very closely with community. We had a number of community accountability groups that really advised us on our trial design, and to ensure that principally that adolescent girls, pregnant women, and breastfeeding women would be enabled to be in the trials, because that's a population that could really benefit from a twice yearly HIV prevention. And so that kind of guidance that we were given in 2019 has put us in this very favorable situation now, where broad populations have access safely to lenacapavir. In 2023, which was again a year before we had our first clinical trial results, we really embarked on a year-long listening engagement with, again, many of the civil society and advocates that could benefit from PrEP, but also Global Fund, PEPFAR, many of the multilateral organizations, the countries, the ministries of health, to understand what was the most priority to them. And what we heard over and over again is, if this product meets the promise, meaning that there's a lot of excitement that this could be have these clinical trial results, that we needed to make sure that the medicine was available as quickly as possible. So in the highest volumes, at the quickest amount of time, at the most affordable price. And so that has really been our mantra for enabling access going forward. And I want to stress that to Gilead, the most important component of our strategy to enable affordable, sustainable access is through generic manufacturers. We know that they have deep relationships in many of the countries that would benefit from this, and also have a supply chain that can enable affordable access. And thanks to the partnership of many partners, including CHAI, Unitate, Gates Foundation, and VITS, we anticipate that 2 generic manufacturers will be actually able to offer lenacapavir at about $40 per year, which is comparable to the price of oral daily PrEP. And that's important because, of course, we want people making a decision based on the product that is best for them, and not because of the price. So some of the measures that we took kind of leading up to it, I see that this PowerPoint is on the screen that we had previously shared. is really being ready and working very closely with our partners on all of our milestones to make sure that we were kind of keeping on a very swift path towards access, but also ensuring that we were communicating with our partners so that they could do the same in the areas which they had fortunately taken responsibility for. So we received our confirmatory results that this was a highly efficacious product in September of 2024. Within 2 weeks, we signed licenses royalty-free with 6 generic companies. And we wanted to do that very early so that they could start to build up their capacity and be ready to supply generic as quickly as possible. So Gilead transferred our technology to those manufacturers over the coming months. We filed with the US FDA in December, but at that point, the tech transfer had already been completed. And then we engaged in very specific conversations with PEPFAR and Global Fund as the 2 major procurers about what they might want to procure from Gilead as a bridge product, so a bridging period until generics were available, and worked closely with them on our registration plan, on our on kind of the target countries that they were looking at first for scale. And was able to reach an agreement with the Global Fund by July of 2025 and with PEPFAR in September of 2025 to put us in the position where not only did we get lenacapavir to Eswatini by just 5 months after FDA approval, but also are now in the position of having 10 countries with access to lenacapavir. In a parallel time period, we had our partners, such as the WHO, announce right after our confirmatory trial results that they were already working on WHO guidelines and that they would be able to complete WHO pre-qualification in the same calendar year as in 2025. We also had partners such as the Children's Investment Fund Foundation that was the first private sector foundation contributor to the Global Fund replenishment to make a big commitment in April of 2025 to invest deeply in HIV prevention. So not just for lenacapavir, but HIV prevention broadly, but also part of their investment was to be able to ensure that these 9 target countries from the Global Fund would receive lenacapavir as quickly as possible. And of course, there were other investments made as well. I mentioned that several partners, including CHAI, Unitate, and Gates Foundation, had invested with several of our generic partners to enable generic access as quickly as possible. So I say all this just to point out that we did not work in isolation. We recognize that our main contribution would be the innovation. Lenacapavir is 17 years in the making, but we really felt strongly that in developing and executing this access strategy, that we needed the wisdom and the expertise of the groups that actually have that grounded in-country experience to move this medicine as quickly as possible. And so we're just enormously grateful at how quickly the organizations have moved. And obviously the real work begins now, because now that 10 countries have the product in market, the implementation role is so critical for the ministries of health, but also the community that really informed not only our access strategy, but also the National Department of Health strategies for HIV/AIDS. So again, as we look towards future innovations within the Gilead portfolio, we have a once-yearly HIV prevention medicine that hopefully will have successful phase 3 clinical trial results next year. We will continue to engage very closely with community first and foremost, but also the major funders and the ministries of health to ensure that at every stage of innovation that we're moving our medicines to market as quickly as possible. So thank you again for having me, and I'm happy to answer any questions.
Great, thank you very much, Emily. And and for this very one comprehensive slide, I see one of the most dominant questions is, will we be able to get the slides? I like to confirm that we will be able to get the slides and share it with the registered participants. There is also another question for you. We were supposed to have questions at the end, but because I understand you're on a time crunch,
I can stay for a bit.
You can stay.
Whatever's best
Wonderful.
for the webinar is fine.
Yes. Okay. Wonderful. So then we will keep the question. You have a question
Sure.
from David Bryden. We will then give you a chance to come in and give a response. Thank you so much for that. And you've touched a lot on a lot of very interesting points. And I like that the question that came in for you was about funding. So just hold on.
So I can't see the question. So if you're
okay.
either reading to me or we can do it in the Q&A. There's no rush.
Let's do it in the Q&A. Thank you very much for your flexibility.
Perfect.
Wonderful. Okay, thank you so much. We've had very interesting plans and what's happening with the ring and what's happening with the lenacapavir. There's progress. Happy to hear that. And as we get towards GC8, this is very essential. Now we are going to hear from one of the very new programs or initiatives. Just checking, is Nomakosi still on?
Yes, I am.
Oh, wonderful. Where did the energy go? Okay. Okay, now is your moment. So please, I'm going to request you to please introduce yourself and ask us and which organization you're from and the work that you do. And also please respond to what lessons that you're seeing as what lessons are emerging from initiatives such as the Empower regarding the introduction, demand creation, and delivery of new prevention technologies, and how can countries strategically position and resource these innovations within GC8 to balance community demand, health system readiness, financing considerations, and long-term sustainability? Thank you, and over to you.
Thank you so much, Joyce. I'm Nomakosi Sibifi. I'm from South Africa. I'm with Y Plus Global, and we're working on the Empower project. So I think one of the key lessons that are emerging from initiatives such as Empower is that successful introduction of new HIV prevention technologies is not, simply a product rollout exercise. It requires early and meaningful community engagement. It requires demand creation and health system preparedness to happen in parallel. So in South Africa, and where Empower is in particular, which is in the Soweto region, we have seen that young women and adolescent girls are highly interested in prevention options that are effective, discreet, and fit their lifestyles, right? However, interest alone does not automatically translate into uptake. Communities need accessible, accurate information about new technologies, opportunities to ask questions, and trusted peers and advocates who can address concerns and misconceptions before products become available. The rollout of lenacapavir in South Africa started on the 8th, and there's been so much hype around it. The demand creation that has happened around Len has been really interesting to see. And with the rollout that has been happening in this week, it has really been something to take note of. However, it is also important to note that, there are many other PrEP options that are available, and young people, young women should then be able to, know about the choices that they have in as far as HIV prevention is concerned. And I think another important lesson is the need to position new prevention technologies within a broader prevention choice framework, rather than just promoting them as standalone solutions. Different populations have different prevention needs, and innovations such as lenacapavir should expand the prevention toolbox rather than replace existing options. So, Empower demonstrated that when communities are engaged as partners in the introduction process, they become powerful champions for demand creation, accountability, and sustained uptake. The Empower project does not offer lenacapavir as the only prevention option, but advocates for it as an option among multiple prevention options that are available. So as countries prepare for the Global Fund Grant Cycle 8, the GC8, it will be important to move beyond viewing lenacapavir solely as a commodity cost and instead plan comprehensively for introduction. So this would include investing in community-led demand creation, provider training, service delivery adaptation, pharmacovigilance systems, monitoring frameworks, and differentiated delivery models that can effectively reach priority populations. Health system readiness assessments should be conducted early to identify bottlenecks and resource requirements before the product delivery. Financing considerations will also be critical. Countries should use GC8 as an opportunity to establish phased introduction strategies that prioritize populations at higher risk while building evidence for broader scale-up. Integrating lenacapavir within existing HIV prevention platforms can help maximize efficiency and sustainability Equally important is ensuring that community-led organizations are adequately resourced to support literacy, demand creation, uptake monitoring, and accountability throughout the introduction process. Ultimately, the South African experience shows that community demand, health system readiness, financing, and sustainability should not be viewed as competing priorities. When communities are meaningfully engaged from the outset and investments are made across the entire prevention ecosystem, countries are better positioned to achieve equitable access and maximize public health impact and ensure that innovations such as lenacapavir reach those who need them the most. So I think it's a really exciting time in the HIV prevention space, and I'm really excited to see, how this rollout plays out and the HIV prevention options that are still available beyond LEN are then incorporated. Thank you so much, Joyce.
Wonderful. Thank you so much. And thanks for bringing back the energy. Nomokosi, I hope I pronounced the name well. Thank you for the reminder that, we need to still maintain an Akapavir, Kabele, Dapring, and all those new technologies as part of a broader prevention choice framework. And it should just be an expansion of the prevention toolbox and not a replacement. Thank you so much for that reminder. Still excited. There's 243 of you. Amazing. If you have any questions, please keep them coming in the Q&A segment. I take note of the questions that are in the chat box, but it's easier to address them in the Q&A bit. Now, before we go into the main question and answer section, I'd like to invite our next speaker, who is on standby, I am informed. Maria, are you now able to speak to us? Maria from Global Fund. Oh, wonderful. So Maria, I know I've already said you're from the Global Fund, but you can also introduce yourself and tell us a little bit about what you do. And my question to you is, how is the Global Fund supporting community engagement and differentiated delivery approaches in countries currently, but also as they align their priorities within the grant cycle? Over to you.
Thank you so much, Joyce. And hi, everybody. Great to be here. My name's Maria Phelan. I work in the Community Rights and Gender Department at the Global Fund. I'm the Senior Technical Advisor on key populations. And I'll share some slides, but I'll whiz through them quite quickly just to try and give you a flavour of what some of the priorities are in terms of HIV prevention for GC8. I hope you can see the slide.
Not yet, but it's coming.
Okay. I think everyone is aware that there is a number of strategic shifts that are taking place within Grant Cycle 8. These include supporting predictable transition from global fund investment, rigorous prioritization, integration, a focus on community health systems and sustainable financing, and optimizing resources and effective co-financing. I say that, I'm sure you've seen this slide before, but I wanted to make it clear that this is part of the kind of overall framework for the investments within the Global Fund under Grant Cycle 8. I'll quickly just draw your attention to the key guidance, which I believe you will have seen multiple occasions, including through this platform, but I wanted to make it clear that there are 3 areas in which you should look to ensure that you can equip yourself well for discussions under GC8 to ensure that indeed we focus on the right interventions for the right people at the right time. So those are the disease-specific prioritization guidance. And for this discussion, it would be the HIV guidance. There's the enabling impact guidance, including guidance around integration, sustainability, tackling human rights and gender barriers to accessing services. And then there's the modular framework, which highlights all the areas in which investment can take place. I'll just quickly speak to this slide, and I'll share these afterwards so that you have them. But as other speakers have said, and I'm really building on a lot of what's been said already, choice is of course critical, and no one product is right for everybody. But of course, we're really excited about new products that are now in place, such as lenacapavir and the ring. But also, it's important that we offer a broad spectrum of HIV prevention interventions. So as you can see, Program Essentials continue to provide that framework for how we might prioritize context-specific interventions. So condoms and lubricant prep, including the products that we've discussed today, harm reduction, VMMC, as well as STIs are part of that overall product essential framework. I'll also draw your attention to differentiated service delivery and access barriers as other program essentials, because I think that answers your question a little bit, Joyce, in terms of what are some of the priorities, and I think you can see them here. In terms of key populations, I think it's important to highlight that within our priorities, some things have changed, but others really haven't. So it's really around prioritizing service delivery based on HIV incidence amongst key populations, as well as resource availability, protecting coverage of essential HIV prevention interventions, and continuing to design programs for key populations based on a trusted access platform approach. So a variety of platforms that can be trusted by key population communities to ensure that those who want to access prevention technology can do so in a way that's right for them. It may need to be that optimization or adaptation of existing strategies may have to take place in the current environment. So that might mean carefully reviewing performance or looking to integrate programs for key populations into primary healthcare. I'll also highlight that we also have had a slight change in the way that we configure some of our guidance. So within the Resilient Systems for Sustainable Health, RSSH, now we have modules sitting to reduce human rights barriers to HIV, TB, and malaria services, as well as those to address gender-related barriers. Much in terms of the interventions has not changed, but of course we know that these are critical interventions to ensure access and availability to all health services, including those for HIV prevention. In terms of the program investments, these continue to focus on expanding access to quality and discrimination-free healthcare, improving health-related laws, regulations, and policies to enable access, and improving legal literacy and legal support to health services, with some implementation considerations that are also outlined in the guidance, which I'll drop in the chat after this. We also know that it's critical to ensure that adolescent girls and young women can access HIV prevention. And in terms of gender equality in GC8, you'll see we have some new interventions, including new prioritized investment areas in a new gender module, also within the RSSH package. And I'll drop that in the chat afterwards so you can familiarize yourselves with that. And a new program essential, which looks at the integration of post-violence clinical care within service delivery. I'll also mention, because I think it's really important for this conversation, I think it builds on really helpfully from the great intervention from our colleague from Y+ Global, community system strengthening remains a priority under GC8, and is another area that is critical in terms of access and accessibility to HIV prevention. The priorities under CSS interventions, also in the RSSH modular framework, include community-led monitoring and advocacy, community coordination and engagement in decision-making, and organizational and leadership development. And you'll see some of those priorities there. It's also important to remember that we have minimum expectations for community engagement to be met throughout the grant cycle. And these are something which communities can utilize in terms of their engagement in the GC8 processes to ensure that you have timely and accessible information that'll help in terms of the discussions and the deliberations around what will be prioritized under this grant cycle. I finally just wanted to highlight some really helpful tools which have been developed by some of our community partners, including those hosting this call. The Community Engagement Toolbox has a really wide variety of tools and information in terms of how to engage in the processes when thinking about how to budget for HIV prevention and other interventions within the GC8 process. New tools are forthcoming, including some of those developed by Eannaso. And I'd also like to highlight some of the other innovative tools, such as podcasts, which have been developed by community colleagues, as well as other information to help communities engage in the overall discussion. But I think the bottom line to highlight here is that HIV prevention remains a priority under GCA. Of course, we have to prioritize, we have to think about sustainability, we have to think about integration, but there's a wide variety of tools and other information to help you to engage in the process to ensure that what is right for communities can be discussed and integrated into those funding requests. And I'll happy to answer any questions as they come in the Q&A. Thank you, Joy.
Great. Thank you very much, Maria. That was really fast and also very, very informative. I see someone saying congratulations, the session is very informative. So that actually leads us to our question and answer session. So there's some questions that have already come up in the chat, and thank you colleagues who have already responded. Thank you, Diantha. I see you provided links to the aspect of the pricing of the dapivirine vaginal ring. I think the first question that I have received from for you as well is which countries are currently receiving the subsidized dapivirine vaginal ring. There's a question for Emily from David. It says, how do you think HIV funding cuts by the US will impact the enabling environment for the rollout of LEN? Has Gilead raised this issue with the State Department? That's the first question. The second question from Sindra. Hi, Sindra. Sindra is asking, I'm not sure who this is towards, but any of you panelists can pick this up, on when will all countries that participated in the LEN studies have access to LEN? And Alan Nyamari is also asking around, my question is in regards to lenacapavir. During the pilot phase in 9 countries, Kenya being one of them, received limited doses and demand was generated. And but now stockouts are being experienced already, and demand for this long-acting PrEP option is still high. So what is going to be done for those who want to access it, and after 6 months, what will happen? There's another question, rather a concern in the chat from Onesimus, who says that a lot of the people, one person who received a LEN described the pain as more painful than pain experienced during traditional circumcision. So what does Gilead recommend for pain management, and what are the side effects for this, and before and after injection? And also he says, please also comment on the spillage after injection, which has also been reported. So yeah, in the meantime, colleagues, please keep your questions coming in the Q&A segment, and we will redirect them to the right people. So who wants to go first? Emily, I see you're unmuted. Go ahead.
Sure, and thank you so much for the questions. Maybe starting with the last question, I took a screenshot of your question so I could pass it on to my colleagues in medical affairs. I will say that most people in clinical trials have reported very mild injection site reactions, and so I think what you reported is not the standard of what we've heard, but we always want people to report issues as they happen. So I've taken down your question, and perhaps the organizers can give me your email address, and so we can follow up after this to make sure that what you've heard is appropriately responded to. Some of the other questions on funding. So Gilead has a partnership with the State Department, PEPFAR, and the Global Fund to reach 3 million people on lenacapavir over 3 years. We have said that we could go above that. That's a floor, but that is the commitment that was sought and most recently updated in April 2026. Both Global Fund and State Department have told us that they are strongly committed to funding lenacapavir. I can't speak to funding priorities for both organizations outside of lenacapavir. I would direct you to ask that of those 2 institutions, but we feel confident that the lenacapavir procurement will go forward. There was a question on when will all people that participate in the clinical trials have access. I think I heard that right. So maybe the first thing I would say is that anybody who has been on a clinical trial for lenacapavir can stay as long as needed until that country has broader access. So no one will be cut off that has participated in a clinical trial. That is a strong commitment for us across all of our medicines. We also don't have a role in allocation of supply under our partnerships with PEPFAR and Global Fund. So we worked very closely with both organizations to understand registration priorities, and accordingly have filed national registrations. But the ultimate decision on when and where the lenacapavir allocation goes is Global Fund and PEPFAR. So it again direct you to them. I think there was a question more broadly on if there were any that I saw in the chat of countries in Asia. I believe it's been publicly stated by Global Fund and PEPFAR that Thailand, Philippines, and Indonesia are expected to receive supply. But again, they could be more specific about their plans going forward. So I think that was all, but if I missed any, please let me know.
Thank you very much for that response, and thanks for the addressing the issue from Onesimus that you'll also scale it up or elevate it to the responsible team. I see Diantha as well, so thank you very much, Emily, for your responses. I think you covered all the questions that were directed to you at this point. So Diantha, over to you. There's another question that I think is also related about the efficacy of the pivirine vaginal ring as compared to LEN. So Joanne Msuya is asking, how will you support, and I think this is also one of those any panelists can take, how will you support Tanzania to access DVR? I'm not sure what the OH means, did not accept to reason that efficacy was below 50%, and they're more interested in LEN and allow plans are okay. Yeah, I think you get the gist. So yeah, over to you.
Absolutely. Thank you, Joyce, and thank you so much for these very valuable questions. So I'm going to address the first question around provision of the subsidized rings. So given the funding constraints that partners have faced, we have created a donation mechanism. So we have been providing the product at no cost to the partners currently. So within the year, we have provided rings, so our donation mechanism, to South Africa, to Zambia, to Uganda, to Eswatini, as well as Indonesia. And we continue to have donation requests come through as well. So there's multiple partners in Kenya, in South Africa, who have requested donated rings. So we are open also to countries procuring the rings through our DVR sales mechanism and through our DVR sales team. But as it stands, to be sensitive to the funding constraints that partners have, we have donated the product in these countries. And then speaking to Tanzania, this has been quite a lengthy process. So unfortunately, the medicines regulator did not approve our product, but we've had subsequent discussions with the medicines regulator, and we've appealed as well. So through the discussion we've had with the medicines regulator, they would like to see implementation data on how the product performs in a real world setting. So there still remains some level of openness from the medicines regulator to receive this form of data. So currently we are, as an organization, the Mosaic Consortium had performed an implementation study called the Catalyst study in multiple countries. We are writing up some of that data, specifically around the pivirine ring, to highlight the improved efficacy on the product. We also have other studies, like for example, the implementation study that happened in Mozambique through ICAP that showed no seroconversions comparing the oral PrEP and the ring arm of the study. Similarly, there's some signals from Kenya data from the Catalyst study. So there's very positive signals around efficacy. We are preparing those, and hopefully we'll be able to go back to the medicines regulator in Tanzania and state our case.
That's good news. Yes. I mean, the ring definitely is one of the options that were celebrated mostly by adolescent girls and young women for its discreet nature, efficacy, and now we're talking about a 3-month option. And this is a valid question, a valid concern. And yes, please, if once the feedback is in, hopefully it's better figures. Yes, you look like you want to say something.
One additional point
Okay.
regarding the 3-month ring, that's our pipeline product, but we're also under development. We have done 2 phase 1 studies on our multi-purpose technology. So that's combining HIV prevention and a contraceptive. So we hope that the results from subsequent studies on this product are positive, but the early signals do show good results. We'll be presenting some of this data at the AIDS 2026 conference, but having communities be familiar with ring technology, like the 1-month ring and 3-month ring, just paves the way for more convenient products. So again, we just encourage more conversation about this product and more awareness.
Wonderful. And this is such a great platform to encourage more conversation around the product. I see many more questions are coming in for you. But I'll first ask Sean, I think from the Global Fund, to come in to respond to some of the questions as well. There's a question coming in from Steve Anguva on, now that the manufacturers have done great work on product development, do we have commitments in regards to supporting treatment literacy or user literacy in this case? There's still another question on the implications of the recent PEPFAR withdrawal of funding of these technologies in low countries and in low-income countries, and how do we draw a human rights violation when it impacts on the rights of the primary healthcare? So I think this talks about integration. A lot of conversation are going around integration, but what does this mean for communities or especially the key population, and how are their rights protected? Someone from Burundi, Muriel, is saying, I would like to know if Burundi will get a chance to receive the ring. Geoffrey is saying, would you kindly connect us to the organizations in Zambia that are offering the services for possible engagement? And yes, the last question is from Sizwe and colleagues. I'm sorry, this will be the last one I'm taking, but if you keep your questions in the Q&A section, the panelists can respond. It says, my question will be to us as communities, activists, prevention champions, when are we starting the advocacy on pricing for affordability and access? And I think that one is for Nomakosi. So I'll invite Sean to come in, and then we'll see if there's any final words from my panelists. Thank you. Sean, over to you.
Thank you so much, Joyce. One, for the webinar and great sharing. It's great to see the number of attendees here as well. I also just wanted to reiterate Noma Cozy's point. And actually, I guess I could just introduce myself first. My name's Sean McGovern. I am the institutional coordinator at the Global Fund, focus on lenacapavir, but support other HIV prevention product introductions. So I just wanted to build on some of the points that were made by Noma Cozy as well as Emily from Gilead. One is first taking a step back. As Maria mentioned, we are supporting the full HIV prevention choice package. And one thing that we continue to do is really encourage countries in their GC8 funding to look across community and user preferences to help inform what is being budgeted for HIV prevention. So that whole toolkit that Maria mentioned is something that we are supportive of and will be guided by countries and communities in terms of what we buy, because not only is choice really critical for every individual, we see in implementation science research that by offering more choices, we actually see increasing HIV prevention coverage, which is really excellent. For lenacapavir specifically, I did just want to clarify the current scope of countries, because I know they've been mentioned by a few individuals on the call. The Global Fund is currently supporting Eswatini, Kenya, Lesotho, Mozambique, Nigeria, South Africa, Uganda, Zambia, in Zimbabwe as part of the first group of early adopters who have all received lenacapavir and have all started their introduction and rollout of lenacapavir, with South Africa kicking off just a week ago. And we're really thrilled by as Emily mentioned, the early introduction of these products really soon after US FDA approval and WHO guidelines. The Global Fund is going to support additional countries, 12 of them, with first deliveries likely to occur by the end of this year. Those are Benin, Botswana, the Dominican Republic, Georgia, Haiti, Honduras, Indonesia, Morocco, Papua New Guinea, Rwanda, Thailand, and are working with a partner as well to support the procurement to Fiji. So this country list is the current one that the Global Fund's working with to provide support, and it's based off requests that we've received. But we're using Grant Cycle 8 and the development and funding requests to really expand access to lenacapavir. And we'll be able to provide support based on countries that come in and request for financing, and really hoping to reach not only more countries, but importantly, more communities in populations across a far bigger geographic diversity. So we really encourage that any interest in lenacapavir outside the scope of these countries, or even going bigger, be directed in funding requests. Lastly, I just wanted to speak to the Kenya example, because it's a really good one. Kenya, as mentioned, is an early adopter country, one of the first to roll out lenacapavir, which will be not only supported by the Global Fund from a financing perspective, but also from the United States government. There will be further deliveries from both ourselves and the US government in Kenya in the coming months, according to their national introduction plan. And it's really important in this period to really support the monitoring that's mentioned, because when we're in the first few months of rollout and demand and supply are trying to find the right cadence, there are indeed cases where there may be gaps, where maybe there's a stock out at a site, or consumption is exceeding expectations. And the goal is really to have country-led and community-led responses in those instances, and to refine the implementation to be able to reflect that supply that's coming in. More is coming, and it's really, I always view it as positive signals. I think we've had issues with other products where deliveries occur into country and they sit on shelves for a while. So this is a good problem for us to have, and one that I think at the country level and with the right folks around the table can figure out the way forward for Kenya. And hopefully with more stock, we'll be able to ensure sustained access moving forward. I'm going to hand it over to Maria just to answer a few of those other questions, and then Joyce, back to you.
Thanks, Sean, and thanks for coming to answer some of those specific questions. Much appreciated. So I think the other question was really around integration and KP programming. And I think, as I mentioned in the slides, although it was a quick slide, so apologies for that. I think there were 3 strategies that we can employ in terms of looking at how to sustain and optimize KP programs. And those are adaptation of programming, their optimization of programming, and then integration is another option where it's feasible to do so. Of course, the effective integration of KP programming will depend on grounding those decisions in the realities of the communities they aim to serve. So community-led or community-engaged assessments, we could consider prioritizing when considering service delivery options to help identify the models that remain accessible, acceptable, and effective for key populations, while reducing the risk of unintended disruption or exclusion. We know that community-based or community-led service delivery points play a central role in reaching and retaining key populations, and they should be retained as much as possible, where particularly for specialized services. So needle and syringe programming for people who inject drugs, for example, could be an area where that might be a better option. And to ensure the continuity of services under new financing and implementation arrangements, we could explore mechanisms like social contracting, not in every option, not in every context, but in some, this might be helpful to formalize and sustain the role of community actors in broader health systems. And of course, meaningful engagement of KP representatives remains critical. I'd also like to highlight that there's a number of community guides to integration, which I think are quite helpful. And I'll drop some of those in the chat alongside some of the other guidance which we mentioned. And also in terms of budgeting and thinking about how to make certain platforms accessible and acceptable. I also wanted to mention the Global Prevention Coalition guidance on trusted access platforms, which was updated recently, which also has budgeting guidance in terms of the different platforms that can be used for HIV prevention, pharmacies, KP competent pharmacies, for example, community-based organizations, and others. And I think it's a addition.
Wonderful. Thank you so much, Maria, and thank you, Sean, as well, for answering the questions targeted to the Global Fund. There is more questions, so I kindly urge the panelists to keep an eye in the chat and please respond. There's an option for answer live, or it's a good opportunity to continue engaging even as we move into the next session. And now I have the privilege of inviting the amazing Lisa Marianne, the Anglophone Africa Regional Learning Hub Coordinator, who will take us through the next session. Thank you, and over.
Thank you so much, Joyce. Colleagues, please just help me to really appreciate Joyce using some emojis on the chat section, as well as the amazing technical panel that we had. My name is Lisa Marianne from the Anglophone Regional Learning Hub that's hosted by Eannaso. And I'll be using this opportunity to sort of like bring this conversation back to the community level, because we've had the opportunity to engage with our technical partners, who I'd love to encourage to stay on the call if you still have time, and continue chatting with our communities, even as they're asking the questions on the chat box, but also listening to some of the community experiences that we are going to be delving into in this particular session, and maybe finding ways of how you can utilize these insights at your level. So colleagues, this particular session, we are going to be talking about how HIV prevention is influencing Grant Cycle 8 funding conversations. As we all know, countries are currently in the process of developing their funding requests, and these are countries that will be submitting their request to Global Fund within window 1, which is this month, window 2, July, and window 3 in October. So already the conversations are going on at community level. All of us have had the opportunity to look at the modular framework, and one of the sub-modules under the HIV module is the HIV prevention module. And this is a very interesting module because it cuts across different community needs and different vulnerable populations that need to be able to access the amazing commodities the technical panel has been able to speak about. So I am going to be inviting key technical people who are part of their country's CCMs and representing diverse communities, and they'll be sharing with us their experiences in the grant writing process, but how is it that they are able to prioritize HIV prevention interventions, as well as commodity procurement when it comes to the writing process in the specific countries, but also how are these considerations taking shape within the constrained resources. Also, we recognize that, Grant Cycle 8 had its own allocations already, right? So within the resources provided, how are they able to prioritize their proposed interventions that regard HIV prevention? And also, what are their perspectives or their community perspectives when it comes to the integration of long-acting prevention methods within the writing process? So I have an amazing panel, and first and foremost, I'll be starting with an amazing person who leads the Kenya KP Consortium. His name is Solo. Solo, I'll invite you to officially introduce yourself. But even as you're introducing yourself, Solo, please let us know what are some of the opportunities and concerns that key population communities are seeing or experiencing within the current available prevention technologies, and how are these concerns being addressed within the current process that KPs are involved in within the Grant Cycle 8 writing process. Solo, over to you.
Thank you very much, Lisa Marianne, sorry. And you can actually acknowledge, am I audible?
Yes, you are audible, Solo. If you have the chance, please just switch on your camera so that our audience can be able to engage with you. But if not possible, please proceed. Thank you.
Where I am, the bandwidth is a bit low. Hello, everyone. Solo from the Key Population Consortium, and I do coordinate the key population conversations in Kenya, whereby we are here to advocate for issues, matters-wise health, matters-wise advocacy, matters-wise existence for key populations in Kenya. So that's where I am. And in Kenya, the key populations are transgender communities, persons who use drugs, transgender community, persons who use drugs, sex workers, and men who have sex with men. That is the context. So let me just, because of the bandwidth, let me just switch it off. So challenges and opportunities when it comes to the new prevention technologies. I can say that the opportunities right now is the fact that we have the choice. Choice in terms of the choice of prevention. You will go and be asked, what choice do you want, even as a key population? You see now we have the different modes of learn. We have from event-driven prep up to now, the latest one, which is the Learn for 6 months. So the greatest, I can say the greatest success is one, knowing this information and actually using it for prevention. And the word choice comes in. We are all diverse and we all have different needs. So I believe right now, as you're thinking about prevention, for me, it's for us to actually get the information that actually suits us in all our diverse ways. If I am a sex worker, maybe I will opt for the Learn for 6 months. But if maybe I don't see people regularly, right? If it's maybe once in 2 months or 3 months, I will use Kabele. You see, so that choice for me, depending on who I am, is very key. The greatest challenge we are seeing is now people actually saying, will we experience stockouts just as we have experienced the pills, even with the LEN? Right now it's 6 months. When I am injected with LEN, post 6 months, will it be there? So there are many questions, calm supply, also the availability. So you'll get that people, yes, there is the land demand, but then people are still worried about, post 6 months. And then come now next year and next year but one, when we are busy now discussing about GC8, we know that the HIV prevention module, especially under the GC8, that is the Global Fund Cycle 8, is like the prevention bit is very heavy. And I believe for us is to think, when we are post the funding, what will happen to all our choices of prevention of HIV? So that is where we are at in terms of cracking our heads. Even as key populations, we want to know post now the GC8, even the counties that did not actually now get support because of the withdrawal of funds by PEPFAR. Those counties, definitely we have key populations. What are we going to do? And I think for me, it's going into these, should I say, these meetings and these convenings for Global Fund Cycle 8, and letting us know the different areas. If there is no service delivery reaching key populations, how do we ensure it reaches? Also intertwined with it is the conversation of integration. So we need to find out, yes, we are preventing, there are programs that were affected, but then there is a push for integration. So for us, what I can say is, as key populations and engaging in the GC8 Global Fund Cycle 8 processes, let's first of all get to know what our gaps are. Come any module, more so HIV prevention module. Then after that, we get to have teams that are actually working on the various facets, from the gap tables to, hello? Yeah, so from the gap tables to, up to costing. Even now, when you're thinking about the numbers, do we have present data? Because that data will be the one that will assist key populations and all populations when we are programming for the HIV response, more so for this GC8. So I would like to encourage all of us, all committee members, kindly get our voices into the boardrooms, because we need to actually now be in the middle of the GC8 processes. Thank you very much, Lisa Marianne.
Awesome. Thank you so much, Solo. Maybe just a quick follow-up question. Do you mind sharing with us how the process has been like for the key populations that you're leading within the writing process? How has it been like when it comes to understanding how to fill the gap tables, doing the gap analysis, prioritizing? Can you just briefly let us know how the conversations have been like?
Wow. So one thing I can say is the entire process is hectic because we are using hybrid models. That is, we are both having physical meetings and virtual meetings. Virtual meetings are more because of the reduced funding and, of course, the reduced capacities in having many people now meet physically. So funding has affected the writing bit. But then now, us as key populations and all other populations being in the space requires the will to be able to know what's going on. So that is number one. The process is hectic. Then number two, if we are not able to actually see the entire process, and if our governments are not, in the forefront, then we stand the risk of actually getting confused. So for us is we have different core leads and also module leads, and also now the rapporteurs and several members. So they are all meeting based on the different modules so that you are able to all be at least getting to know what's going on in each module. If you look at the engagement, of course, requires one to be, knowing when is the next meeting, when are we meeting? Some meetings are going on even up to the weekend or past 5 p.m. or as early as 7:30 in the morning. So what does that mean? We require people to actually do the coordination. And if we are not actually now in Kenya, we have a database of email addresses. We need to be in those databases. So that is what has actually assisted us coming together as key population and saying, Solo, you take this role, the other person take this role, and then actually now splitting amongst ourselves and amongst our typologies. What do we mean? What do we bring to the table? So you need to learn, you need to make the modular framework your friend, you need to consult widely, whether it's physically or even virtually. Make sure that you actually ensure that you actually now get the guidance, because we have people who actually understand the guidance. Let us make sure that we ask for the guidance from people who are leading the process, because we are all learning as we continue, but then I can say that guidance is available, and that is what has made that the key populations actually to continue, doing our best. Challenges are there in terms of coordination, because it's like a factory. It's many things going on at the same time. So we need to put in coordination there as well as learning as we move. That is our experience, Marianne. As we continue, because Kenya is actually submitting in the second window, so we need to have our application ready. Yes. Thank you.
Okay, thank you so much, Solo. I recognize that your time was constrained, so I just want to appreciate you. But in case you have the chance, please hold on, because we're going to be having a Q&A session. And I believe that KP networks who are on the call would love to learn more from you. I have been privileged to see how well coordinated you are, and how you're even writing your, your interventions or your priorities. And I'd just like to let the technical partners know that, the KP network in Kenya wants all the commodities. And I know Solo can back this up. So Solo, if you can, please stay on. But if not, we just want to thank you in advance for giving us your time. Please allow me to shift the conversation just a little bit, because we do have an amazing advocate of prevention. Her name is Yvette Raphael from the Advocates for Prevention of HIV in Africa. Yvette has been at the forefront of championing prevention methods, when it comes to HIV prevention in the region. Even though I know she's mostly based in South Africa, I know she's been doing amazing work in the region. So also I'd want to just bring in Yvette quickly and, allow her to introduce herself, give us a brief of the amazing work that she has been doing, but also ask Yvette, what have been some of the best practices that you've been able to implement when it comes to increasing demand creation on HIV prevention commodities, but also what tips can you give our communities when it comes to ensuring that their interventions are community-centered and they are responsive to community needs, especially in this grant writing process. Welcome, Yvette.
Good afternoon, and thank you so much for inviting me to this session. As you mentioned, my name is Yvette Raphael, and I'm the Executive Director of Advocates for the Prevention of HIV in Africa, but also, more importantly, in the region, I am the chair of the African Women's Prevention Community Accountability Board. And I see the question around how do we engage communities, but importantly, how do we ensure demand creation responds to the current needs? The African Women's Prevention Community Accountability Board are the architects of the Choice Manifesto, where the idea of having a choice in the clinic was basically based on all what we've heard today. We have injectable PrEP, we have 2 monthly, we have 6 monthly, and very soon we'll be talking about an injectable PrEP. There are rings, there are pills. Pills are becoming more and more longer acting, right? So there's discussion of a monthly HIV prevention method. So it's easy for us to be confused and also follow on to a prevention method that we would like our own favorite, not forgetting that these options are not for ourselves. These are for women, these are for young people who are in the community and would like to make a choice. And it's clear for us, and we saw that promoting choice in the healthcare sector, in the healthcare facilities, is an opportunity for us to expand PrEP, prevention uptake. As you also know that convincing somebody that is not sick to take an intervention, they might think they do not need it. They do not understand their risk at most of the times. But how do we ensure that we keep these young people and women and men engaged and make sure they take these methods? It's by ensuring that they go to the clinic. And when they go to the clinic, they need to be offered a choice. But more importantly, they need to be taken into the care system where they are tested and ensured that they are able to take up HIV prevention method. We must also remember that the decision on who and what methods are available currently that makes our life difficult, it's very seldom on the person that needs the HIV prevention method. Most of the decisions are made, one, by the funder, by our governments based on what they can afford. And that is what makes HIV prevention not cool, not acceptable, because most of the time when a young person goes to the clinic, what they get there is not what they would like to access. And we know currently there is a big hype around lenacapavir. And we know also that most of these healthcare facilities do not have the commodity at hand that we'd like to see. But instead of our healthcare facilities ensuring that when young people go there to ask for HIV prevention, some of them will present for the very first time at a clinic. And instead of turning them away, how do we then offer them HIV prevention or testing, then a method that's available, and then saying your method of choice would be available next time. So I think we need to do more. We need to understand social demand creation is not about us. When we create demand for HIV prevention. We create demand so that our communities go and access HIV prevention. But also, how are we then working towards making HIV prevention cool and something that people want to integrate in their sexual and reproductive health, lifestyle. This thing called HIV prevention is very different from treatment, because treatment, we know people have to take it. But with the HIV pipelines, prevention pipelines, and also the commodities that are made available, I think we need to do better by our communities. I also would like to say, as an organization, APA, we are engaging with young people. We have sessions where we educate young people around HIV prevention methods and choices, empowerment, where they speak to their peers on how to participate in ensuring that HIV prevention does become a reality. We also need to know, when we engage young people, they engage differently. I'm so proud of the young people in South Africa we work in 5 countries: Zambia, Uganda, Malawi, South Africa, and there's another country that I'm leaving out, but it's a mistake. So all of these young people are excited. They engage differently with the launch of LEN. Young people in South Africa, for example, are doing HIV prevention parties. They are going to the clinics themed, and they want to access HIV prevention in a theme, dressed up and all of that, and they're making it a date. But what we are missing is that these young people are not able to get integrated into the system. When it comes to engaging young people in the policy space, it's important for us to understand that young people will only engage if the space is safe for them to make to put forward their ideas. And that is the engagement we are currently having with those who are writing these amazing country proposals. Make space for young people to tell you how they want to have PrEP delivered. This differentiated care delivery models that we are talking about for young people, it's not the same as what we mean. I spoke to young people and they said, how about us creating a space for the nurses to come and offer the PrEP where we are? The mobile clinics are gone, but we can have PrEP parties, and the healthcare worker can come and offer those services where we are. So we need to think out of the box if we want the future to be HIV negative, if we can see it without having young people excluded from the conversation, but also implementing their ideas. We are past the time where we just allow young people to just be giving us ideas and not implementing it. Young people are much smarter. They want to see their ideas implemented, and we should give them that opportunity. There's so much that we can do to ensure young people are part of the discourse. Young people are seen as leaders. We also need to make the space for young people to be able at the table and make sure they participate. I know on this call alone, there are many young people, and I can see their comments. Many young people who have been participating in HIV prevention, and now is the time for them to lead, and we must let them. Thank you so much for the opportunity to present a unpopular view for HIV prevention.
Amazing, Yvette. I have most definitely heard of the, PrEP slumber parties in South Africa, and I'm really happy to know that you and your team, have been part of this amazing and innovative ways to make HIV prevention look cool, look sexy, and make it a lifestyle and that is exactly what attracts young people. So thank you so much, Yvette. I do recognize your time constraints, so you may not be able to sit until the Q&A session. However, with your consent, please allow me to share the details of your organization, your website, your social handles on our post-webinar brief, which we will be posting after this amazing conversation.
Thank you so much.
Thank you, amazing Yvette. As we move on in the spirit of, lived experiences and strategies, I would like to invite an amazing AGYW that I've gotten to interact with in my work, and she will introduce herself. She is the AGYW AYP representative at the Kenya Coordinating Mechanism, and she'll be sharing with us how they have been organizing as AGYWs to ensure that their voice is at the center of the grants Cycle 8 writing process in Kenya. She'll be sharing with us some of the experiences, but also how have they been approaching the HIV prevention module with fellow AGYWs, how have they been mobilizing, and what key considerations are they putting at the table in regards to AGYW HIV prevention? Welcome, Ms. Miriam Wambogo. The floor is yours.
Thank you so much, Lisa. You really set me up. Thank you so much, Mercy and Alan, for setting me up for this conversation. My name is Eannaso Webinar, just as Lisa has said, and I'm from Kenya, and I represent the AJW, the adolescent and young people in the country coordinating mechanism in Kenya. And thank you so much for your question. And also now, from the perspective of the AJW, the most important priority in DC8 is not just access to a new prevention product. It is merely an access to prevention choice. Because now for the many years, HIV prevention options for AJWs have been limited. And in this GC8, we have an opportunity to change that through a broader prevention option that includes condoms. We still cannot refute that. That also includes the oral PrEP, the PEP, and the long-acting prevention options such as cabotegravir, lenacapavir, and also dapivir and drain. And this is particularly because AJWs are not a homogeneous group, and also different AJWs experience multi-sectoral or even other forms of circumstances and preferences and also levels of risk. And therefore, one prevention option is not okay. We need to have a basket of prevention options for the AJWs. Right now, we've been really psyched up for LEN. And this is potentially because the lenacapavir, or maybe say the long-acting prevention methods, are coming in to address the barriers that the AJWs have been mentioning over the years. That includes stigma, privacy, and also difficulty with adherence. But that does not really limit that there are AJWs who were still adhering really well to oral PrEP, because as I said, there is still a basket of prevention. So first, even in the GC8 is one, we have ensured we prioritize youth-responsive and community-based models. And we've also proposed that we need to prioritize peer-led approaches, because as young people, we really love spaces where we can trust, spaces where we feel safe, and spaces where we feel respected and understood. And our safe spaces that we've built over the years through the support of our partners, specifically Global Fund, because even the other day, I think 3 weeks or 1 month ago, we did a visit to the different wellness centers that Global Fund support. And the tremendous work that is done through the peer educators and the work that is done through the wellness centers, it was really remarkable. So these are still the systems, and even as we are approaching GC8, we have looked into also expanding from the 5 counties out of 47 to at least 25 or 19 counties as per our national strategic framework. So we are looking to ensure that we also support the existing support structures, such as the youth-friendly centers, most which were closed after the funding cut from the USA, but still with the limited resources that we have with Global Fund, we are still finding ways where we can be able to ensure that we do not lose the gains that we've gained over the years. When I mention our country, and even from the guidance that Global Fund gave, is one, we need to have integration, because AJWs do not experience HIV risks in isolation. There's a lot of realities and also a lot of vulnerabilities, which also include gender-based violence, unmet sexual reproductive health and rights needs, and mental health challenges that we need to ensure that integration comes in and sorts that issues. And that is also not to say that integration has really worked at the moment, because in the country we've seen HIW or even AYPs dying because of not going to the facility and integration to the outpatient delivery, which is very hectic. And as young people, we really require a little bit of grace, because to some extent, sitting in a facility for almost 8 hours to just access services, and remembering that you're not sick. If you're going for that HIV prevention support, it's not because you're sick, it's because you just want to protect yourself. And even if now you're HIV positive, then you do not want to be reminded that you're HIV positive. And as part of even HIV prevention that we've been talking about, you your treatment as prevention. So you will also not want to be reminded that you are taking ARVs. And integration, to some extent, answers to some specific needs or some specific challenges that the AJWs have been facing. But the direction that I've been seeing our country moving forward is approaching it step by step or case by case basis. The facilities that are not fully integrated because of such cases, but the facilities, because their system allows, it has gone through that. And in such spaces, we've seen tremendous progress, and we've also seen young people being able to access services. Now for GC8, we have prioritized our safe spaces. We have prioritized even institutions of higher learning. Most of our AJWs are based in schools. We have people in the tertiary institution, in colleges and in universities. So the model that has been there has been the wellness centers or even the youth-friendly spaces, which now have been integrated in a public facility. So before, a lot of people used to go to a public facility, which created a huge barrier for young people to access services. So we, as part of now ensuring that we are meeting the young people where they are, just as how Yvette has mentioned on how they're doing it in South Africa, then we still want to ensure that in GC8 we are meeting young people where they are, including also community pharmacies, especially for PrEP, so that someone does not have to get a barrier from even the existing systems that we have in the country, which as part of the writing we're trying to address, and also other non-traditional service delivery points, including the border riders, the market spaces, so that now we are creating a space where we do not have to ask someone to close down their business to come and access services. So they can be able to access services from the area that they are. Of course, with the limited funding, you will not want someone to just close their business to come and access service. And and then now, we have done a lot of integration of services, even now in GC7. And as part of sustaining all of these gains, it's really important for us to move in that same direction. So we have combined HIV prevention with HIV testing, contraceptive services, STI services, cervical screening, GBV support, mental health support, and referral services. And this is usually done at the community level. So you go and meet the HLWs at the community level, and you're able to really understand the realities of young women, at the community, beyond the health facilities or beyond the other systems that are in the country. So as now we are gearing forward towards even GC8, community-led approaches or community-led demand creation should not die just because money is not there or just because the resources are not there. So with the limited resources, we can find ways where we rationalize our activities, and we are able to continue to invest in peer-led approaches. So the GC8 prioritizes one, the peer educators from our module, and even the other module like HTS and PrEP, and also the treatment care and support that I'm part of. We've just ensured that we have support for peer educators to continue doing the demand generation work, and also to provide information at the community level. We also have PrEP champions who will come in and, make PrEP as a very safer option to choose, and also make it very fancy, just as Yvette has mentioned. And also we want to do adherence camps in GCA. We would want to have adherence camps where young people are coming in. We talk about adherence, we talk about risk, we talk about even side effects of those same drugs, and making it as fancy as it can, so that now we do not have to make it look like a pill burden. It's not a pill burden issue, but it's about HIV prevention. So we also want to do as much as this, and I hope that these specific proposed interventions suffice even after the grant making and the grant signing. So for the HW, what I would say on the engagement. So for me, I am part of the core team, and also we have an HW who's representing us in the GCA writing secretariat. So beyond her, we've been able to have as many HWs and even as many young people to be part of this process, to be part of even reviewing these documents. And I would say it's as weird as having a meeting at 8 p.m. on a Sunday, just as Solo has mentioned on how hectic it is. It is very hectic to even follow through, and even going to meetings with no support, but you just have to attend because you are looking at millions of Kenyans that are looking towards you. You are representing millions of adolescent girls and young women in the country. So it's just the passion to ensure that that one HW does not get to being infected with HIV. And also now, if we fail to do it, then the cost will be even much higher. We're now ensuring that this HW, one, gets the ARVs, two, has to adhere, and three, has to attend all the appointments, including viral load. So it is just the ensuring that you close the tap, especially in prevention for the HWs. So for one message is clear for the LJWs is we need to expand prevention choice. We need to also bring services closer to the communities and invest in integrated and peer-led models and ensure that young women are not just active participants, but we are also part of design and implementation of this response. And then also from the statement that was brought by the Y Plus Global on engagement of the young people in GCA, to also ensure that young people are also implementing this grant. I know it can be hectic to just ensure that our systems are right, but we have done quite a lot. We have done quite a lot in ensuring that now we understand the grant and also we understand how best to implement it. And I am sure that we as young people want to see zero new infection in the country. And even as a population that leads new HIV infection in the country, it is not a smiling matter. It is not a very good thing to hear. But we have done quite a lot to find innovation and to find innovations, innovation of activities that really is high impact and also ensures that these other HAWs is not going through the vulnerability that they are going to. And we are hoping that by 2030, we will be able to reduce the new infections and even end AIDS-related deaths in the country. Thank you so much, and over to you, Lisa.
Thank you so much, Miriam. You have addressed gaps. You have explained how you're organizing and how the writing process has been for HYWs and even some of the priorities that you're putting within the module. So I just want to really appreciate you. Please stay on the line, Miriam, because we're going to have an exciting Q&A session. And I know there are people who'd want to learn from you, and especially just your organizing skills and how you're building a movement of AGYWs in Kenya, especially during this writing process. I know I have previously seen you with an I Ring, I Write t-shirt, so I know the prepping the prepping partners here are also really, really proud of you. Allow me to just quickly move on to our next and last speaker, considering time is moving so fast. And our next speaker is Mr. Rahim Nasir. Rahim is also the AYP representative in the Tanzanian CCM. And for you, Rahim, your question is almost similar to that of Marianne. Please share with us how the writing process in Tanzania has been, but also what are some of those priorities, key priorities that adolescents and young people of Tanzania are putting or are documenting within the writing process in regards to the available prevention tools, and also which are the tools or commodities that young people in Tanzania are really creating demand for, and how can this be realized in Grant Cycle 8? Also, what remains relevant and acceptable and youth responsive, also keeping in mind the Tanzanian culture. How are you considering all of this even as you write for GC8? Over to you, Rahim.
Asante, Lisa. Am I audible? Thank you. As introduced, my name is Rahim Nasser, current Executive Secretary for Tanzania and Youth Reproductive Health Coalition. I'm part of the co-writing team representing young people in AGYW. Until recently, I was also a member of the CCM in Tanzania. Straight to the point, new prevention tool for AYP. What is in the context of GC8? So I'll say all young people are advocating for the increased access to broader HIV prevention packages. We have for Kabele, DVR, PrEP, HIV self-test, and GC8 represent a critical pivot point for traditional siloed prevention to integrate youth-led and highly innovative programming. And going forward, part of the authorities that we put forward into the concept notes, the current concept note we are writing right now, to accommodate different users' preferences and low access to barriers, we proposed to have these HIV self-test and assisted self-test options for young people. And there is also developed, emphasized on the moving beyond daily oral PrEP and capitalized on long-active technologies, including and long and Kabele, which we anticipate it will drastically improve adherence and confidentiality for young people. These interventions also come with a needs to needs to have more studies learning where on its side effects, if there is any acceptability, and as intervention support the rollout of long-acting agent for PrEP. We also had and published digital prevention tools, telehealth, online demand creation platforms. For instance, in Tanzania, we have a 117, a toll-free, and 116, where young people can access by calling and getting information on HIV and getting and be directed on where they can have get the services they need quickly. So some of the interventions we had to put forward, and some, for instance, we also had the integrated sexual reproductive health platforms. Rather having a standalone HIV tracking, we are now in the GC8, we are optimizing, integrating prevention, so we can have testing into primary health care and youth-friendly services. My previous speaker have mentioned it clearly and in a better way, that young people, when you mix them, they become somewhat feeling isolated. But when we have friendly services where they be young people and not be reminded that they are sick, because they're not going to the hospital being sick. And it's a good thing that young people all over the world have similar issues, different environment, but similar issues. So as my colleague from Kenya just explained the some of the issues we are facing here as well, and we have put it into priority so that we can be able to address them in GC8. We have challenges though in sustaining sustainable financing for preventions. We have seen many innovations, prevention innovation fails to scale due to insufficient domestic investment. We have seen major SBCC programs that were working well to change behavior. For instance, in Tanzania, we had one of the wonderful program I can recall called Fataki, where we were able to address the older men, older men who are targeting younger girls, called Fataki. It was well known in across Tanzania. Whenever you see a young adults approaching a girl, you just shout Fataki, and that person knows what it means and it can stay away. It was really, really helpful. But rolling out programs which are working have been challenges, and as young people have called for the funding to youth-led organization, we have called for resources to demand creation and community mobilization. We have seen even in the GC7 when we called for reprogramming after fund shift, most of SBCC programs were cut down, mass media programs were cut down, and this also affects demand creations and community mobilizations. We keep on asking for the long-term sustainability plan beyond Global Fund as young people, and accountability as well. Tanzania, we have ATF, AIDS Trust Fund, but accountability of these programs, of this funding portfolio, it's what also we like to see, that it is accountable. The money, the resources collected for the HIV response are actually used for HIV response instead being shifted elsewhere. We dedicated budget for preventions and training for new interventions. Right now in GC8, things are slightly different. We have to combine the prevention into one for AGYW, AYP, and KVP. Recently writings or recent years, KVP were able to develop priorities and have their own ceiling, and AGY young people, they also had their own separate ceiling for when they are putting priorities. But this time, we are experiencing that all the activities, all the preventions activities needs to be aligned in the setting where KVP and AGY needs to work together. And OVP also include adolescent boys and young men, which were necessarily reside on KVP, but is now needs to be aligned. And we're knowing age or might slightly be different of those for KVP group. However, we are now, for the sake of integration, we have been able to integrate well during the writing, and we are now learning how to coexist and put together our intervention so that we can utilize the scarce resources we are facing. The engagement for the Cape orators has been saying our engagements in all these priorities, generally I'll say it's like 90 85%. Hearing from Kenya say there is exhaustion and all that, but Tanzania things a bit have been well, I'll say. We have been able to participate in NSA's dialogue, country dialogue, creating priority. Of course, there is challenges given the previous on the previous model where all constituencies had to sit on their own, create their activities, priorities, and submit them. But given the resources issues, we were not able to have that. But we had we had an opportunity to create priorities, and as you know, all priorities activities in the concept note require starting them with uh, justifications. And young people had opportunity to review the country allocation, participate in these dialogues, and be able to discuss the justification for priorities. And we're able to setting that we are sending the writing team with all the bullets they need to defend their priorities and ensure that they are costed in the main concept note. On the issues of relevance, acceptability, and youth response, yes, absolutely. Across dialogue on GC8, young people have emphasizes on success that should measure not solely by the number of prevention tools, but rather if young people are actually using them. We are for the innovations, but these innovations needs to be tailored to diverse young populations, young people, and special attention to be put on HYW, young people living with HIV, and those young people with disabilities, and be country context specific prevention approach. Tanzania, it has how to put it, some sort of the way of life different from other countries, so it needs to consider the context specific preventions approach to be respective treatment, confidentiality, reduce stigma and discrimination, and to put focus on peer support mechanisms. And here was mentioned a few challenges that as we expand to other regions, we also experience challenges, needing to train young new peers we are reaching so that they can be the voices for young people. And in this writing grant currently, trainings have been not so much encouraged, and we are wondering if we are moving to those places, how are we going to equip newer young people, those who have graduated by the virtue of their age or being married, AGIW, how are we replacing these peer without training them in these new technologies we are proposing? Yeah, participation, we call for participation in design and implementation and real-time feedback, so to ensure that if we want to prevent prevention youth services from becoming absolute or underutilized, young people now in Tanzania, we are shifting from being passive beneficiaries to active actors, auditors to the health systems. We are now invested our core shift from verified real-time feedback loop, and now we are scaling community-led monitoring and youth focus interventions for AGYW and ABYM. And as I mentioned, that we are combined preventions for AGYW and KVP in the regions. Even in community-led monitoring, we are putting emphasis on the areas where we can work together, looking for those criteria we are seeing fit, so that young people can access all these new innovations and services. How we can prioritize CLM to train networks, community health workers to be youth friendly, to systematically document services provisions gap, stock out, and even the cases of stigma where we experience a lot here in Tanzania, so that we can be able to turn qualitative youth experiences into hard, actionable data. Youth-led organizations ensure that GC8's investment remains strictly accountable and action needs for young people on the grounds are met. So to summarize that, we are involved, we are ready for new approaches, and we are also ready to advocate for these new approaches and utilize them. And as Babatunde, the former UN FPA director, used to say that the world is the safe hands in the hands of young people only if they are trusted with it. So trust young people hands to carry the world, and we'll carry it forward. We have now facing challenge that in our time, preference is going up and resources are going down. But trust us, we'll maneuver it and do it well. Thank you, Lisa.
Amazing, amazing, Rahim. And thank you so much for sharing with us, some of the advocacy efforts you're putting in the writing process. And congratulations for leading Tanzania AYPs. I do recognize we are really, really running out of time. So what I'm going to do is, even as I invite Joyce back to just give our closing remarks and a few action points, please, if you do have a question, type it up in the Q&A section, and our panelists will be able to answer you directly there. But also, we are going to be sharing a post-webinar brief in the next coming days, and some of your questions are going to be addressed there, courtesy of our amazing panelists. Thank you so much, guys. I've been your community host, and once again, I want to wish you great evening or afternoon, depending on where you're coming from. Back to you, Joyce.
Thank you so much, Lisa. And that was a very insightful session. Very nice to hear the collaboration in the communities and how communities are approaching the GCA process. Again, affirming what the Global Fund mentioned as areas where they placed safeguard as part of this process. We are out of time, so I'm going to take this very roughly. The partners have spoken, they've shared the work that they're doing, they've shared how new prevention technologies are likely to reach communities, and everybody is working so hard to ensure that we expand options, and we cannot have options without choices. So these two go hand in hand. I've heard that HIV prevention needs to be cool. Thank you, Auntie Vet, for reminding us that. It's also very evident that there's a lot of guidance and a lot of support already out there. So all we need to do is just take it up. And yeah, I'm just happy that we are all aligned with the new global AIDS strategy as well, United to End AIDS for 2026 to 2031, talking about the 30, 80, 60 targets, talking about the promoting rapid access to technological innovations, and importantly, community-led delivery for the 30, 80, 60 targets. And finally, people-centered differentiated services. A lot of speakers today have talked about meeting the communities where they are, demedicalizing the whole aspect of prevention, but importantly, we are a diverse group, communities are a diverse group, and no one prevention option works for all. So it's important for us to continue expanding the prevention pipeline and give people an opportunity to choose what works for them. Thank you so much. I am very grateful for the 149 of you who have stayed till now, and also grateful to the 240 something that were here earlier. Thank you so much for your very active participation. Thank you for joining us in this session. Lisa has mentioned that we will be sharing the post-webinar brief. We'll be sharing the recordings. And should you have any other questions, please feel free to reach out on different partner socials. That's it from me. My name is still Joyce Ouma from UNAIDS, and until next time, thank you and adios.
Adios. Bye.
Thank you so much, everyone. We are grateful. Thank you, our technical partners. Thank you, our community. Thank you, Joyce.